Sharon, Lisa's over there. Lisa's over there.
So your focus is on centering?
Yeah. Are you familiar with the model? Oh, that's
Familiar
great.
with the model and looking towards adopting it.
Great. Well, we'll know a lot more by this time next year. We're leaving in August to do a randomized pilot trial in Tanzania and Malawi.
Is everybody set? We go ahead and get started.
Yeah, we're just a smidget away. I wish we
Well, we have
So we're going to start in just a few seconds, actually.
naturally.
Yeah.
You know.
You have to go where it's going to be the easiest when you're going halfway around the world.
Great. So welcome. Thank you for joining us at today's event, which is entitled Delivering Quality Antenatal Care in Low Resource Settings, Examining Innovative Models and Planning for Scaling Up. My name is Sandeep Bathala. I'm a Senior Program Associate with the Maternal Health Initiative here at the Woodrow Wilson Center. Today's event is brought to you as part of our Advancing Dialogue on Maternal Health series, which works to address many critical and neglected maternal health issues. And it is generously supported by the Maternal Health Task Force as well as UNFPA, or the United Nations Population Fund. As many of you know, the Wilson Center is a formal memorial to our 28th president, and in his honor, we aim to bring the worlds of policy, practice, and academia together to better inform one another and to learn from one another. I just wanted to give you a few notes about today's meeting. We're being webcasted live, so what that means for folks here in the room is that when we do get to the discussion, I'd ask that you use a microphone, and my colleagues will be around the room with the mics. And I also ask that you introduce yourself and your affiliation so that folks tuning in can hear where you're coming from. I do want to make two additional notes. One is that if you do need a Wi-Fi password, it's listed on the wall. It's WC, it is cap sensitive, so those two are capitalized. June without the E, which is lowercase, and 006. I also wanted to point out that the hashtag we're using for today's event is hashtag MHDialogue. And for those tuning in and listening to me on the webcast, if you are interested in asking a question, feel free to post it on Twitter, and a colleague here will indicate that a question came via Twitter. I now want to direct your attention to our speakers. We have available more detailed bios, so if you didn't grab it on your way in, feel free to grab it on the way out. But we're going to start today's discussion with Dr. Metin Gulmezu. He is a coordinator of the Maternal and Perinatal Health and Preventing Unsafe Abortion team at WHO, or the World Health Organization. We're then going to hear from Carrie Klima, who's the program director and clinical associate professor of the Nurse Midwifery and Women's Health Nurse Practitioner programs at the University of Illinois at Chicago. And then we're going to hear from Faith Mugai. She is the director of clinical operations at Jacaranda Health. So thank you. That's it.
Good afternoon. I first would like to start by thanking the Woodrow Wilson Center for the kind invitation and giving us the possibility to talk about our guidelines on antenatal care here. So I'm going to talk about a little bit into the antenatal care research that we have conducted, and that led to a particular form of antenatal care that has been widely adopted. And then in the second part of my talk, I'm going to present the ongoing work on antenatal care guideline development. Antenatal period, as you know, is an intense and complex period that, if we take it in the continuum of care, includes a lot of important aspects of women's health. It's a period where we need to do health promotion activities, but also it's about birth preparedness, it's about complication readiness, and it's about providing certain interventions to the women. Now, in mid-1990s or early 1990s, colleagues in WHO questioned the current antenatal care model that at the time was the typical, perhaps doctor-led, frequently visited model of 9 to 13 visits during pregnancy. And what they did was they reviewed the evidence on interventions that need to take place, and they hypothesized that if we focus on only those that have been shown to be effective, then perhaps we can give them at less frequent intervals, and providers and women would have more time during antenatal care to discuss the questions women may have and other aspects of care. So that led to the widely known focused antenatal care or basic antenatal care that is known in terminology used in some countries. What it basically does is when women come for the first time during their pregnancy, they are evaluated through a classification form, and then they are either assigned to receive the core package, which is for all women, and if they have some risk factors or other issues that may require more different kinds of care, like being risk at diabetes or hypertensive disorders, then they are asked to follow the specific guidelines for those conditions. And it was hypothesized that around 25% of women may receive or require this additional care. So based on the evidence reviewed, there were 4 visits critically timed during pregnancy. The first one was in first trimester, between 8 and 12 weeks. The second visit around 24 to 26 weeks. The third visit around 32 weeks. And then the fourth visit at 36 to 38 weeks. And if there were any complications or issues, and then obviously additional visits were added. And during these visits, all the necessary things were provided. And this model was tested in a cluster randomized trial, comparing it to the traditional Western-style antenatal care model, and found to be non-inferior in terms of some critical health outcomes, like low birth weight and maternal severe morbidity. And as you can see in this slide, a large number of countries actually adopted and adapted this model. And in some countries, they added additional visits, but I think the 4 visit became the sort of new standard, and perhaps it played a role in 4 antenatal care visits becoming a global health indicator. Then in 2010, we updated the Cochrane Review on antenatal care models. And when the trial was first published, there were 2 trials. One was the WHO trial, and then there was a Zimbabwe trial conducted in urban settings in Zimbabwe. And during that period, a third trial, a rural Zimbabwe trial, became available. And when we looked at the totality of the evidence, there seemed to be an increase in perinatal deaths in women assigned to the fewer visits model. And we conducted a secondary analysis of the WHO trial because we had access to that data, and it seemed that the increase in deaths were due to fetal deaths rather than neonatal deaths. And we have over the years seen that actual delivery of antenatal care tends to be variable, and many factors play a role in uptake and continuation of antenatal care. So we decided to embark on this antenatal care guideline project to see how we can address the antenatal care recommendation also within the context of new sciences. And in WHO, since 2007, we have a guidelines review committee that mandates us to follow certain criteria for synthesizing and assessing the quality of evidence. And it was actually an opportune time as well, because the Women and Health Initiative in Harvard University were just starting a project called Adding Content to Contact, and Annie and colleagues are here from that institute. And we collaborated with them because the project aimed to look at innovative models of antenatal care and also integration of antenatal care with postnatal care and other vertical programs. So it seemed a good time to look at all these antenatal care issues and quality of antenatal care issues together. And we had a meeting in April earlier this year to scope and frame the questions for the guideline. Now, when we embark on guidelines, especially in a complex topic like antenatal care, the immediate public health thinking is to reduce adverse outcomes. And that has been our focus, and that has been the focus of the earlier trial. But I think we should also consider individual level factors as to why women attend or do not attend antenatal care. This is important for every intervention, but I think for complex interventions like intervention such as antenatal care, it is much more important because it also determines the care-seeking behavior later on, so it may have implications on other issues. So for this guideline, we are addressing two types of questions. One is, what are the evidence-based practices that women should receive to reduce adverse outcomes? And the second is, how this care should be provided. And the how obviously is a bit more complicated. Our focus is going to be on essential core package that all women should receive. And we don't intend to focus on complications and their management because it would make it unmanageably big. And we also, in order to improve the usability of our guidance, we want to look at different models in terms of who is providing the care, where the care is provided, and how that care is organized so that it meets the needs of the users. To address all these issues, we've developed 6 work streams. The first 2 are more straightforward. We are going to look at individual interventions such as supplements, health promotion, counseling, breastfeeding advice kind of interventions. We are looking at tests. Antenatal period is full of tests, as you know. It's about predicting whether the women will develop preeclampsia or preterm birth and so on. But we will also look at barriers and facilitators to access and of provision of care. And to complement the more higher level, policy level issues, we are going to review large-scale programs, primarily those focused antenatal care programs, how they have been implemented and where there have been issues and failures or problems with implementation. We are going to look at health systems and community level interventions, and we hope to experiment with modeling because we have not used modeling in our guideline development before, but it seems that for such a complex issue, it may be helpful. In 2012, we published a guideline shortly called Optimize MNH. That's the task shifting guideline for recommendations on which cadres of health workers should deliver or can deliver safely and effectively the evidence-based practices. And in that guideline, which included more than 100 recommendations, we used what is called the DECIDE framework. This is a framework, the long name is Developing and Evaluating Communication Strategies to Support Informed Decisions and Practice Based on Evidence. It's a bit of a forced acronym, but anyway. It's an extension of the GRADE framework that some of you may be familiar with, where GRADE framework actually synthesizes the evidence and then applies certain criteria to look at the quality of evidence. And what the DECIDE framework adds is, especially used for health systems interventions, it allows us to look at the issues around benefits and harms. We always look because that's the main determinant, but also look at feasibility, acceptability, whether a recommendation is likely to have an impact on reducing inequities and on resource use. When we develop our guidelines, we make many judgments, and the panels make judgments. And by making these judgments explicit, at least we can indicate where we are putting our emphasis on. So it's a useful process for transparency. I will briefly go over these. As I mentioned, we are going to look at interventions. We are going to look at tests. Those are the first two streams. In the Optimize guideline that I mentioned, we also conducted systematic reviews of qualitative research as to barriers and facilitators to implementation of task shifting programs. And in this case, we are going to do similar reviews for barriers and facilitators to women attending antenatal care, coming to antenatal care, as well as providers' views about how care is delivered. As I mentioned, we will review programs as well. And the health system interventions can be quite critical for acceptance and success of an antenatal care program. We know about financial incentives, we know about voucher schemes and so on, but also how integration actually can take place. And as you know, with the recent maternal death analysis, indirect causes have become much more prominent. So we need to look at antenatal care incorporating and embracing all those issues around malaria, around HIV, MTCT, and related interventions, because antenatal care has to be the platform for delivery of those interventions. Modeling, as I mentioned, we will experiment, hopefully. But the important thing, I think, is we are going to look at both the what and the how. And how tends to be obviously much more context specific and less easy to generalize. Outcomes, as I mentioned, we often tend to look at health outcomes, and again, maternal morbidity, infant neonatal mortality and morbidity will be important. There will also be outcomes, critical outcomes related to specific interventions. But I think what has been lacking in antenatal care especially is to look at also women-centered outcomes. Why actually women come to antenatal care? And I think somebody who has no health problems probably doesn't come to prevent hypertension or something else, but rather maybe to learn about what's going to happen, how birth is going to take place, and how it needs to be planned. So we will try to capture those outcomes in our recommendations. So this is our framework, and I don't know if you can read it. You probably don't need to read it, but basically the health system organization needs to be planned and executed, and that relates to both the antenatal care core package and additional care packages. And all of these have an impact on how women experience and the care that is being received. And if we are successful in providing a effective service with a woman-centered approach, then it will obviously have an impact on utilization of services. And utilization of services hopefully will lead to increased positive outcomes. At least that's the hypothesis. So with that, I think I will thank you. I want to thank both USAID, who has been supporting our work in this field for many years, and also Women and Health Initiative, and the Adding Content to Contact project, which has been very helpful in stimulating and starting the work with us. Thank you very much for your attention.
Thank you. Actually, you have us all teed up. You can have a seat whenever you're ready. A couple of questions that I wanted to pose when we did get to the discussion portion was specifically, around user perception of care. So it was great to see that that's put into the model, and then also to hear you talk about integrated services, because I think that's something we certainly have to factor, especially when we're talking about low resource settings and when we're talking about limited resources and sustainability in our discussion. So thank you for teeing us up for the discussion that I know I'm looking forward to. But before we move on to that discussion, we have quite a bit more exciting content. So whenever you're ready, Carrie.
Again, thanks to the Woodrow Wilson Institute for inviting me. Just a quick show of hands, how many people know what centering pregnancy is? Good, so most everybody does, because my time does not allow me to talk about everything about the model of care and what's happening in low resource settings. So very briefly, centering pregnancy is a model of group prenatal care. It has been in existence in the US since 1993. It's being practiced in hundreds of sites across our country and many places throughout the world, in mostly the developed world. And we have really excellent data, both a randomized trial as well as large retrospective studies that have shown that centering pregnancy in our own country has been effective at reducing preterm birth, increasing breastfeeding rates, increasing rates of patient satisfaction. So basically the model contains three components of care. The healthcare part, which is what providers and consumers are pretty familiar with. Interactive learning. We know women want to learn what's happening not only to themselves in pregnancy, but what's going to happen as they become new mothers and parents, what's going to happen during the birth process, what's that transition going to be like, and then community building. And that's where our typical model of individual care really falls short. Our waiting room model of care, where lots of people come, sit in a room, wait for a while, go into an exam room, talk with a provider, and then leave, doesn't really leave a lot of opportunities for community building. So this model builds that in and really helps to strengthen communities. So when we think about low resource settings, they require that as well. So the healthcare part has two components. One is self-assessment. So women partake in their own assessment of themselves. So they do their own weights, they do their own blood pressures, they own that information, they know and they learn what that means. They learn how many weeks they are pregnant, they figure that out. And then there's a provider assessment, which is similar to, for those of you who've had babies and those who want to or may once have already had them, the provider assessment that we do to make sure that everything's going okay. The interactive learning part is what happens in the group. And this happens through facilitative discussions with a provider, as well as the women in the group that help to guide the discussion. We have a curriculum that centering focuses on that looks at all of the required learning that needs to take place, as well as things that provide springboards for discussions. And then community building happens because the groups develop a history with each other. They're all going through the same thing at the same time. They learn from others who have already had children before. They learn about fears and they learn about successes that people have made on their own. And they develop a group of peer support amongst themselves. It's based on 13 essential elements. I'm not going to be able to go through each one of these, but you can certainly check that out on the website and in many of the articles. But one of the great things that I think touches on what you said about women coming to care, one of our participants said, we came at the same time, we left at the same time, and something happened the whole time we were there. My observations of prenatal care in the developing world are that we may come at the same time. A lot doesn't happen while we're waiting for many, many hours. We see someone for a very short period of time and then we leave and my whole day is gone. So you sort of get the reason why maybe it's hard for women to come for prenatal care. So we conduct groups in circles so that women can all see each other. Everyone's on the same plane. There's no leader in a circle. Everyone is just as important as everybody else. So we've taken, my research team at the University of Illinois in Chicago have taken our successes of centering pregnancy here and looked at, well, how can we change centering from the traditional American view, 10 visits, to a FANC model, which is 4 visits, which is the model that's being practiced in both Tanzania and Malawi, where we are starting to do our initial work. So we called this our proof of concept study, and this happened a year and a half ago. We went to Malawi to find out if group prenatal care would be feasible in the setting, and would it be acceptable to both the women and the providers. This is a billboard sign in Malawi. I'd never been to Malawi before, but seeing a sign like that on the side of the road gives you the reason why we need to make sure that we're doing something about trying to prevent this. So for those of you unfamiliar with the eastern part of Africa, that's the 2 places that we're working. And we, in our very short time there, were able to answer both of our questions about feasibility and acceptability. So we took the original design of centering pregnancy. We have an initial visit that women enter the system in, where they have a history and physical and some of those beginning tests. We had groups of 12 women with similar due dates. And we worked very hard to develop centering pregnancy along with the guidelines of FANC. So we have 4 antenatal sessions and 1 postpartum session. They follow the same model. They have a beginning part of 30 to 40 minutes where they have their check-in, their time with the provider, and then the rest of the group time is spent in the group learning from each other. And you can see some wonderful pictures. This is from our pilot proof of concept study. So we did do some preliminary work, working with the ministries of health and the administrators in the sites we were going to use ahead of time, because we do have 2 contacts who are in both Malawi and Tanzania, and so those people helped to make this project possible. I went to Malawi to do a 2-day training to train the midwives, the community health workers, as well as an administrator on how centering pregnancy works. And then we piloted the first 2 sessions with women in Malawi in 2 sites at Kabadula Community Hospital, which is about 2 hours out of Lilongwe, and Ansala, which is a smaller community health center. We used direct observations, and we did focus groups with both the providers and the women over the time that we were there. So these are some of the things that we found. The providers were excited to do the model. They struggle with the ability to care for large numbers of women in short periods of time and realize that those limitations are impacting how well they can do their job. And they really looked forward to this opportunity to try to do something different. The women loved it. the midwives worried about, could they really learn how to take their own blood pressure? Could they really figure these things out? And they not only figured it out, but loved doing it. And one of them said, well, now I know what those numbers mean that they write on my card every week, which was her blood pressure. So she didn't know what that meant, yet she'd had it written on her card numbers of times. The providers really loved being able to interact with the women in a different way. They felt like they were finally practicing midwifery as they were taught in school. And they were surprised by the ability of the women to not only come together in a group which had not known each other before, but to have really rich discussions. We learned from, and these groups were conducted in Chichewa, which is the native language there, so I didn't understand a word they were saying, but our research assistants were taking notes, and so what they were finding out was that the women were learning all kinds of new things in just one session. They learned that there were treatments for sexually transmitted infections, which they had been told through their village networks that there wasn't any, so there wasn't any reason to go to the hospital. They learned about the truth about HIV. We have an activity that helps to talk about transmission. And in the focus groups, we asked women, how would you feel if there were HIV positive women in the group with you? And they said, now that we know what it is, it would be very important for those women to be here because they would need the extra support. That's what the women in the group said. And they were very happy to be doing everything together. They didn't want us to stop. So they said, we want the other 2 sessions that we hadn't yet developed yet. So they felt that the midwives were teaching them with patience, which I think was the first time the midwives as well as the patients experienced patience. They were asking each other questions. They were engaged with each other. And over since we did 2 sessions, we had a little bit of lag time, about 4 or 5 days. When we came back for the second day, the women were standing in a circle singing a song. And they learned how, from the women who'd had babies before, how to ask questions, what to be concerned about. The midwives were nervous that no one would say anything, so after the first day when everybody was talking, they felt a lot more at ease. And I am convinced this is the first time these 2 midwives ever smiled at work. So we left Malawi with a renewed sense of knowing that not only is centering pregnancy feasible, but it's acceptable. And we started to prepare for an RCT. We have current funding from the NIH in an R21, and we are going back to Africa in August to do a small randomized pilot trial in both Tanzania and Dar es Salaam, so a very urban area, and then the same 2 sites in Malawi. Being someone who's been involved with centering for a long time, starting it in very large bureaucratic systems, my concern is certainly the scalability of something like this in a place that sees more prenatal women in a day than any site I know of in the US. But we have a team that's very experienced, and we have a lot of support in both countries to really make this work. So hopefully by next year at this time, I'll have excellent data to talk to you about. We have a large group of people both in both countries as well as here in the US that have helped to make this project get to the point it is and hopefully be successful as we continue our scale up. This is the song that the women, I wish I had our video clip, but it wouldn't, I was worried about it playing here. But this is the song that the women made up. In Malawi, they use songs a lot to create support amongst each other. And so this is the song that they were singing when we arrived on the last day of our pilot study. And they came up with this themselves. The midwife said, let's make a song. And so the women came up and they sang it and sort of moved around in a circle. And it was a pretty moving experience to show up and see this happening after only 2 days. So it really showed me that it really is a universal belief that women want to be well in their pregnancies. They want to have a healthy baby. I think we don't always give them the tools and the opportunity to make that happen. So I think centering is the way to make that happen. Thanks.
So you spoke a bit about community building, and I will say when we were putting together this session, and I had mentioned reaching out to you, colleagues on our team that helped put these together had talked about their own participation in centering pregnancy, and I have to say the enthusiasm I felt when you asked if people have heard about it, like the way hands went up, you could sense that sense of community in the room itself. I also think some of the interesting points you made during your presentation really spoke to quantity and quality. You talked about 10 visits, if I heard you correctly, 10 visits being the model in the U.S. and then 4 abroad. And I think that can, when we get to the discussion, to really talk about the difference. Is there a difference when we think through quantity and quality issues? But without further ado, I want to turn it over to Faith. I know that she does actually have a video for us to view, so I don't know if that's before or after, if you just want to let me know. Before? Yes. Okay, so let's do that then.
Maternal and neonatal rates, particularly in sub-Saharan Africa, are high. Jacaranda's mission is to provide a high-level, quality, affordable service to the clients that we serve. What we're trying to do is provide a safe environment, but also a memorable environment. We want mothers to think about their delivery 10 years down the line and actually have a smile on their face.
The difference with this hospital, like that night, before the morning came, before I delivered, the nurses were with me, we talked all through, they came to check me, yeah, and it was clean, always clean.
When we came to Jacaranda Health Facility, actually you really get amazed with the care that you get, because nurses are like 3 or 4 that actually come to attend to you. And every time that you feel uncomfortable or pain or, you know, the attention that you receive, it's good.
Not only are we client-centered, we are also developing the next tier of healthcare professionals. They are ready to provide you the service you deserve. They treat you with respect.
Since I was a small girl, I admired to work and to serve other people. Then I see this baby growing, I feel as if I've grown together with the baby and the mother. And I feel, yes, this is part of me, this is part of my quality care to this particular mother and the baby.
My dream is for women here in sub-Saharan Africa to have access to quality services and to be provided with dignified care. I didn't pay anyone for that video. Those are actual clients, and the babies you saw there are from, their parents went through ANC with us and carried them through the continuum, through their birth and so on. So it gives me goosebumps because in the past 2 years, I've been a part of a journey where we're trying to transform healthcare delivery in Africa, and we're doing it in a way that we're translating theory into practice, and that's really fun. So first, let me start by thanking representatives from the Woodrow Wilson Center, and as well as the Maternal Health Task Force, for inviting me to speak here. It's a true privilege to be able to share some of the work we're doing in sub-Saharan Africa. So Jacaranda Health is implementing a scalable model in the delivery of affordable quality maternal and child health services in East Africa. In my view, research informs best practice, but also highlights gaps. Policy sets direction, regulation, and so on. There's a middle piece that is missing, and that's implementation, translating theory into practice, demonstrating what works and what doesn't. This is where I feel Jacaranda fits in, a means of proving concepts that impact the delivery of cost-effective, patient-centered quality care in low-resource settings. In the past 2 years, we've established 2 health facilities in Nairobi and are seeing approximately 600 women per month for outpatient services in one facility. In East Africa, maternal mortality rates remain high. Our primary focus for health care delivery is peri-urban settings where the population density is high and access to safe maternity care is low. Now, it's not because there's a lack of facilities, but more so the quality of care provided in facilities is poor. There's a national mandate where public facilities offer free maternity care, and therefore such facilities may be functioning at higher capacities, which has the ability to compromise the quality of care. There are additional factors that influence decision-making to accessing care, such as cost, transport, respectful care, and so on. Our ideal client, the urban poor, the woman who is a casual laborer and earns $2 to $3 a day, but can save for her delivery and demands a clean environment to be cared for with dignity. A woman who recognizes need for care across the continuum of her pregnancy and accesses antenatal services immediately in order to have consistent care that will be beneficial to outcome. Now, that is not the case. We see clients struggle in decision-making to access care. They often come towards the last trimester of their pregnancy. They do not often save, and therefore this period becomes a financial emergency and constraint. The woman who traditionally cares for others, her children, her spouse or partner, extended family, but has not set a minimum standard in terms of accessing quality services for herself. She may not be the primary decision maker in the home, and therefore antenatal services may not be a high priority, let alone choice of facility to deliver. Distance has been seen to be a barrier. Why spend money to access a facility? So they wait to access a facility at point of delivery. An overall lack of education concerning pregnancy and delivery. As an organization, we have had to take significant strides in understanding the population that we serve and implementing strategies to ensure women access services earlier and maintain care through the continuum of their pregnancy, postpartum care, and general reproductive health. We've taken a human-centered approach in understanding our customer needs, focus groups, client satisfaction surveys. We originally started out with mobile clinics, linking the community partners to offer ANC services. The promise was to increase access to ensure that women started ANC earlier on, with trained community mobilizers penetrating critical access points in the community, such as markets, churches, women's groups termed as chamas. This is coupled with clinical support, where we pair clinical representatives with the mobilizers to provide in-depth educational sessions around accessing ANC, birth planning, financial preparation. Lessons we have learned is that even though this was a good grassroots approach, we're going to the people within the community, women felt more safe and comfortable accessing care in a standalone facility. Our outreach efforts have been beneficial and a great link to the community. But as we assess our operations, we have taken a more targeted approach in a number of areas. Patient-centered care. We are focused on the client experience and conduct customer service satisfaction surveys to elicit information on what we are doing right and opportunities to improve. Some of this also has to do with building efficiency in our system, simple things like client wait time during the visit. We have been thoughtful about male engagement early in the pregnancy to drive positive decisions around accessing ANC early and choosing a place for delivery. This has included personalized invitations to our clients' partners, as well as educational material on what to expect when she's expecting and financial options. We have leveraged on technology and business innovation as a means of engaging our clients and stimulating demand for traditional services. One thing we have realized is that even though our population may be lower income, every client has a mobile device. The cell phone works wonders. And therefore, how to use it to their benefit? How do we use that to their benefit? We send scheduled text messages to remind clients of visit appointments. We provide education on birth planning, danger signs, and once again, messaging on savings. We have a mobile savings option called Mama Kiba, where with each ANC visit, we offer the option to deposit funds into this portal to save for safe delivery. Our overall costs for 4 ANC visits are about $1, and for a normal delivery, approximately $90. I believe drawing clients to care, it's all about the people. In the areas of human resources, we believe that satisfied providers will satisfy our clients. The satisfied client will then go out and share their experiences. They are our direct link to the community. We have seen our volumes increase based on word-of-mouth referrals. In order to build a stellar group of providers, we have taken on upfront investments in training. We do not rely solely on formal education, so standardizing the onboarding process, orientation, and so on, validating skills. We've standardized practice through protocols and standard operating procedures, performance management, and performance-based incentives. We have set standards in place that demand for customer service, for example, scripting, role modeling, and assigning customer service champions. Task shifting to what we term as patient care assistants, a supportive role to the midwife, to maximize time with our clients. And so during those visit times, we're actually doing education and so on. In terms of quality, this is thrown around loosely, particularly in sub-Saharan Africa. We're delivering quality. What does that mean to us? Applying the best practices of Lean Six Sigma to improve patient safety, building efficiency, standardizing processes, and monitoring compliance to these developed standards. Patient-centered design, gathering data from our clients to inform us of their needs and developing a patient-centric environment. Monitoring clinical indicators to drive practice. Human resources and developing more effective nurses and midwives. Development of a career ladder that drives the professional development of our workforce. Building an area that is emerging, middle management. Technology, measuring impact, communicating with our clients, and moving towards clinical decision support. We're seeking independent validation of standards through accreditation bodies such as SafeCare. That's a link to the Joint Commission International. If we're able to communicate and validate a certain level of quality, we anticipate it is a draw to our services. And then there's business innovation and ensuring a seamless supply chain. When clients come in, do we have what we need to provide good care all the time? Through our experience, we have found that when we bring a client into our system, through the strategies I've discussed, our clients commit to care, and they're with us through the course of ANC. And therefore, our efforts are really to get them in the door sooner. Our strategy for impact has two pieces. We will achieve direct impact through scale and service provision, and secondly, through influence. By sharing our innovations and partnering with other providers, we are building clinical innovations and health systems, validating successes so that they are adopted by the public and other private players in the health landscape. We are working to document what we learn to influence best practice, particularly in clinical quality, workforce development, and health service delivery. The Maternal Health Task Force can attest to that. So is our approach different? Within our low-resource settings, we're doing what is right with a central focus on optimal patient outcomes. Our goal is to positively impact the lives of women, families, and communities. By building a passionate, talented, and committed workforce, we're able to service our clients. These clients, in turn, steer the community towards the quality service we provide. We see women and children every day, and we're positively changing their stories, and in turn, the stories of families and communities. Thank you.
Thank you. Maybe while we wait for Faith to get settled again, she started her presentation by talking a bit about knowledge, and I'm wondering maybe if we just go down the line while she gets settled, but if either of you have any input, and of course we will open this to the audience in a moment, but I get the moderator choice to choose my question first. And I wanted to ask, what are some of the knowledge gaps that need to be addressed to improve quality of antenatal care in low-resource settings, from all your opinions? Whoever wants to start.
I think one of the things that we desperately need to know is what are the barriers, more than the obvious ones of roads and time, and what are the things that will make women come and make them come earlier. I know that was one of the, certainly one of your goals, and because my experience in Malawi was that women don't traditionally come for care until well into the second trimester, so you've missed a valuable opportunity to perhaps intervene to help achieve better health outcomes. And so I think there are many internal factors that happen in women's communities that are not just about roads and time, but there are really personal decisions that are being made that I don't think we have a very good handle upon.
Just to add, I think we have a problem measuring quality as well. I don't think we are good in particularly measuring quality in a standard and replicable way. So I'm positive, both with your centering and Jacaranda Health, the way you are describing it, satisfaction with care and coming back to the clinic again for more of the same is easy, and it sort of oozes when you listen and when you show the slides and so on. But at a larger scale, we don't know. I mean, our measure of antenatal care has been 4 visits, and that's simply not good enough, I think.
Mm-hmm. I think a big thing working with our women is trying to understand what drives their decision making. And so how do we communicate quality or articulate quality in a way that is meaningful to them? And that has been the challenge. And so our facility is clean. In terms of nurse-patient ratios, during the laboring and so on, we have one-to-one attention. Our costs, I believe, for what we're giving, we give 3 meals, 2 snacks, 24-hour monitoring for a normal delivery. This includes everything that goes in it, so it's a full package. The medications, the medications, the maternity pads, everything. But yet we see that public sector hospitals are flooded, and my beds are still empty. And so, what is their value? And that has been a challenge for us. We do monitor clinical indicators. We do measure patient satisfaction, but how do we communicate to them so that it's meaningful for them? Well, going for accreditation means a lot to us. Do they care? Probably not, you know? And so I think our biggest challenge is communicating what quality is in a way that is meaningful to the client.
So why don't we go ahead and open it up a bit too? Otherwise, I can certainly keep asking. But I do see we have a question already in the front. So why don't we take these 3 questions here, one's behind you and then 2 in the front. We'll give you a chance to answer and then we'll take another round after that. And please do introduce yourself and affiliation.
Jill Gay, What Works Association. And my question is for you on how you, if you could elaborate more on differentiating between the clinical outcomes and the women-centered outcomes. If you could just talk a little bit more about that.
We'll grab the other 2 and then get there.
My name is Francoise Kayuzia, and I work with Action for Reproductive Health Uganda, and we work in the rural settings. My question goes to Faith. I have actually seen jacaranda in the city. I just wanted to find out the possibility, and it looks like you offer services to people who are able to pay something. Do you have a plan of offering these services to people that are not able to pay? Because where I work, no woman can even afford $1, and if she does, the man will take it. Of all the things that I have heard, I haven't had anything to do with a man being involved. We do male involvement. I just wanted to know whether you are planning to ever involve men or to even cross and go to those people who are not able to pay.
So while we wait for the mic to come up to the front of the room, I do just want to point that Francois comes all the way from New Jersey to our sessions and comes to a lot. So it's always great to know that folks aren't even just tuning in from whether it's national or international, but we do have folks that travel to come to these sessions too.
I'm Indira Narayanan, an independent consultant, and my question is for Carrie. I think it's a great idea to try centering in such a situation. But obviously one of the challenges is you're going to cut down a 10-visit thing to a sort of a 4-visit. What sort of priorities are you now going to focus on, and what are the criteria you've set to select those priorities? For example, in some of the areas, things like in IPTP coverage, it's far below in some of the countries than we would want it to be. So are you sort of selecting your priorities based on the data of the outcomes in these interventions, or what are your criteria?
Great. So should we go ahead and answer them in the order they came? I think the first one was addressed to you, Metin, around clinical versus women-centered outcomes. What's the difference?
Yes. This is a general difficulty in our guidelines, because when you issue an international guideline from Geneva, it's always difficult to capture different constituencies' outcomes and what people value, whether they be clinical doctors or midwives or women. For this project, we are doing reviews of studies about what matters to women in antenatal care to see whether we can actually capture those outcomes in a satisfactory way. But I don't think there is any easy way to do those. Normally, in our guideline panels, we include 1 or 2 consumers or representatives, but it's generally not very satisfactory, and it's difficult to get a proper representation from one person in a group of 20 people who may be experts, who may be loud and strong, you know. So, but I think we'll see if through a systematic review whether we can capture important outcomes.
Thank you. So thank you, Francois, for your question. I'll start with the area of male involvement. And I actually did mention in the presentation that we are actively doing a lot to engage the male partner or spouse, going to the lengths of creating invitations. So we have physical invitations. We have educational material that not only outlines what's happening to your spouse during this significant period, but also we're talking money to them. So there's a lot about financial savings and so on. We try and engage them so that anytime the spouse or partner comes to the facility, we're touring the facility with them and so on, just to get them involved in the process. So we're actively taking a stance because we understand that in some of our areas, the male actually is the decision maker. Are we planning to offer people services to people who cannot pay? We have actually enrolled in the National Health Insurance Fund, NHIF, which is similar to Medicare, Medicaid, that sort of thing, our government payer, to be able to assist us in reducing costs and providing greater access. Getting the accreditation has been a challenge just because of bureaucracy. So that has been one sort of strategy in trying to deliver care at the lowest fee possible. We are a social enterprise and we are a business, and so we have to pay people, we have to recover and run ourselves as a business, so nothing is free. That reality, having said that, is that our influence strategy is about partnering with the public sector. What I do is sit on a lot of key stakeholder forums and so on, and what we're trying to do is, with our proof of concept, start taking baby steps to actually have dialogue with our government and public sector. Because if we can provide free care on the front end and there's some sort of mechanism on the back end to reimburse us, that is actually one way public and private is actually partnering, which is a concept that is thrown around, but we are trying to actually make it happen.
No, go ahead.
Okay. It was certainly a challenge to think about taking something that's 10 and already full of a lot of information and making it 4. So we started with FANC and the guidelines of FANC and what going to both of the countries, both Malawi and Tanzania, and talking with the ministries of health and providers about what are the key essential things that we need to try to focus on. So in both countries, especially Malawi, prevention of maternal to child transmission is a high priority, increasing the rates of testing, significantly increasing the rates of couples testing, and reducing stigma so that women who do test positive will accept treatment and treatment for themselves and their babies. We also identified from talking with our partners about identification of problems in pregnancy, earlier identification, and both countries have a large push to have women deliver within health facilities. And so we actually have an interactive exercise that gets women to talk about, so what are some of the barriers? And if you had this barrier, what could you do to overcome this barrier to get to the hospital? Recognizing the signs of labor in enough time when it may take you much longer to get to the hospital than just going down to the end of the block. So it's complex, but all of those things are interrelated. So if women are better able to understand the signs and symptoms of labor, they're probably also going to know if labor is coming too soon. If they are well versed in what are the complications and signs of complications in pregnancy, they may identify those earlier and then and have the abilities then to go to a health facility in order to have treatment. We have the ability, one of our sessions does focus on couples testing and inviting their partners or spouses to come and to one of the sessions. And in that session, we talk a lot about HIV testing, why HIV testing is important for the health of the family, so not just the woman, but the health of the family. We're going to be very interested to see if men come to the sessions. We don't have anything really to base on whether they will or not. And if they do come, what happens in those discussions? So that's still an unknown, although couples testing is happening independently in both of those countries in the settings in which we'll be working. So we think it's certainly a possibility.
I think I saw a hand come up over here, so if you could just wait for the mic.
Thank you very much. My name is Magdalena Serpa. I work for PATH and Newborn Health. And I wonder if in your experiences, you've seen that if investing more time in teaching the women or mothers what to expect as content in each antenatal visit, has that improved the rates of compliance, or is it a little bit late? Should we be doing that education before? Should there be a checklist so that a mom knows what she would be receiving at each visit?
Do we have any others, or looks like there's one in the back?
Hi, I'm Noah Carr. I'm with Friends of the Global Fight Against AIDS, Tuberculosis, and Malaria. I was wondering if you guys could talk a little bit about how to include a TB response, response to tuberculosis in antenatal care, and if you guys have any recommendations for higher level planning or also community level planning.
Is there one more, or should we start with these two? Oh, there's one there.
Hi, I'm Heather Rosen. I had a question about the Centering Pregnancy Project, and I wasn't familiar with the model, so I'm very interested to hear about it. Could you talk a little bit about the process and the reactions of, I guess, the health facility and the health the providers, where you were doing these kind of pilots testing, and what their response was to this? It's such a fundamental change in the way they were going to do their services, So I'm just curious how that you got them to buy into that, or, if there were concerns and how that process went.
So we had a question around TB and the response in antenatal care. We had one about a provider reaction, and I want to build off of that one. We're through this round. And then also checklists from women itself and what's prioritized. So I don't know if anybody in particular wants to get us started, or just down the road.
Maybe I can respond to the TB question. Not that I have an answer, but I think it's difficult because, some of these disease-oriented programs are so independent that it is a struggle to bring them into mainstream antenatal care, and they have created their own pathways. And TB is probably particularly a complex issue because of where TB-positive women should receive care and so on. Whereas, with HIV, it's more communicable, or it can be contagious and so on. But I don't think that's necessarily a barrier. It's just that I think the health system planners, I don't think, felt the need to plan integration in a systematic way. So it needs to come from a national planning level.
I'll go ahead and respond to Magdalene's question in terms of investing more time in teaching the mothers. Do we see greater compliance? I will say yes. What I would also say is that there's been a provider sort of angle as well. In taking a patient-centered approach, our providers sometimes think that if I bottle everything into one conversation and have this 1.5 hour discussion with a woman, I'm providing patient-centered care. And so there's actually need to, and Frank does it very well, in breaking down per visit what we're going to
what we're going to educate the lady on. Big thing is that when they access services later, that becomes a challenge. So once again, it's triaging what is important based on when they come to us and so on. We have actually kept our lines open, so we have a triage line. So one thing we do in terms of opening access to our midwives is giving them a line to call if they have any questions. And so that also eases the process.
So in regards to the providers' experiences with centering pregnancy, so before we even undertook going to Malawi for this initial proof of concept study, we asked our people in country to talk with them about what did they think about this model. They did a short presentation that we provided to them to get their initial thoughts, and it was overwhelmingly positive. And so when I went to do the training, one of the things we did with the providers was focus groups, and after they did the training as well as after they did the pilot testing, because it's a critical partnership. The providers need to want to do this. Anytime change is introduced into a system, even if it's a bad system, it's going to create a lot of stress and chaos, and so we had to prepare them for that this might get a little messy. We're not quite sure how we scale up to this, but we're going to start small and we're going to scale up to doing this right now. And if this works, then we're going to move up to the next level. And what we found was that the providers were so happy to be interacting in a different way that they were willing to put up with some inconveniences, because when they were doing groups, they were having fun. And they were feeling like they were making a difference, which I think when you work in low resource settings where you see high volumes of people, sometimes it's probably hard to get that satisfaction that maybe you're making a difference, because you're so busy just trying to make sure everyone gets their HIV test, make sure, that everyone gets weighed, make sure that everyone gets a blood pressure, and if you have a little time, ask them how they're doing. And when that's your sort of daily focus, I think you lose sort of sight of the fact that there could be another way and that you could have a very different experience. And so when they came out of the group, they're like, wow, we talked with them like they were part of our, we were part of their lives, and they talked to us like that. And so I think their experience was so positive that they, I think, are going to be willing to maybe put up with some confusion at first, which I am totally prepared for.
It's interesting that all of you actually talked about providers in some context or another in your presentations, which, it speaks to the title, right? How can we talk about quality without not talking about those that are providing the services? But there was some difference in what you all talked about in terms of, if I heard correctly, Faith, you talked about standalone services, and then we heard a little bit about integration when you're talking about testing, possibly. So I'm wondering if all of you could just make a comment on integration and multiple services under one roof. Does that decrease provider workload? Could that improve quality of care? If so, how? Or are we hearing from folks that standalone is a preference, and how we juggle all this then?
What kind of integration?
Integration of other services, whether it's around TB, that was one question, I know we see some more natural fits with some things versus others if we're talking about testing, but just any sort of integration, whether it's integrating with the children that they may already have, their child care. If multiple services are under one roof, how would that factor into quality of care? Does it factor into quality of care?
I think when you have, the goal is that you want women to come earlier for care, you want that care to mean something to them, that it has to be efficient. And oftentimes, if everything is in a different place, it can't be efficient. We see that here in the U.S. when, you have to go to this place to go to this service and another place to go to that service, and then, you have to go across town and call this person to get that service. If If it takes you 3 hours to walk to your prenatal care visit, you don't want someone to tell you after you've waited for a few hours that, oh, by the way, you have to walk to this other village to get this paper signed or something. It's not respectful of the women, and we have to make it so that everything happens where you are. And I think that that's just part of a changing definition of changing our systems to meet the needs of the women, instead of asking the women to address the needs of the system and work with the system. It's sort of flipping it on the other side.
I think it's really hard, particularly in East Africa, to say you're providing a specialized service. And that's what we've been doing. And we're learning lessons as we go because, we started out with providing ANC services. It was good quality. It was in mobile clinics. And they said, okay, so you're doing ANC, and then where do I go for delivery? So we built a hospital. And so we built a hospital, and we're offering really good ANC and then inpatient deliveries. And then they say, you delivered my baby. Where do you want me to take my baby? So now we're offering child services and so on. And so if you see where we're going, we're now focused on maternal and child health. But then as a specialty, there's a lot of investment that you need to put up front in this specialized care in terms of training our providers and so on. Now, if I start adding TB, malaria, just general inpatient, it waters down what we're trying to do in a sense. And so, there's the question of, do we specialize our inpatient services but then open up the outpatient services? We haven't gotten to that trajectory yet. Right now, we're looking at maternity and child services as a specialty, and we want our providers to be the best in what they're doing. So that's where we are.
Mm-hmm. So responding to users across the board in both cases. Mm-hmm. Did I see another hand go up around here somewhere? Yes, I thought I did.
Thank you all very much. My name's Dan Irvin from World Vision International. Amongst the many challenges you've noted, I'd like to ask you about the challenge of early identification of women in pregnancy and the reality in which we don't often identify them until the second trimester. Could you speak about the gravity of that, how serious that is and the ramifications? Any of you, or all of you.
Okay.
Did we want to pose any more in this round? Does anybody else have any questions?
Maylin Fung, California Health Corps. I just want to say how impressed I am by your leadership and doing all of this. And how do you keep going? I was just listening to Faith saying, oh, we found that we need the hospital, so we get a hospital. How do you keep going? How do you sustain this amount of passion? How do you keep your team going in this?
Great, so why don't we take those two and then we'll open it up again. So a question around the challenge of early identification and the gravity of not.
That's a really interesting question because I've seen mothers access our care when things went wrong. And so they had never had any antenatal services and so on, were in their homes pushing, were exhausted and walked in ready to collapse and so on. That's where our outreach services now becomes instrumental because when we have our community mobilizers and we have our midwives going out in the community, we're not focused on just pregnant women. We're focused on women and men. Anyone who's able to get somebody pregnant and anyone who has the potential to be pregnant. And so when we're going into churches and we're going into women's groups and so on, we're talking to a variety of audiences and not streamlining the audience to get people in the door faster.
I have to agree that outreach to women who aren't even pregnant yet, so that young girls grow up learning that when they become pregnant, they need to access care as soon as they know that. Centering itself doesn't, until women get there and learn about it, it's not going to draw them in any earlier. But perhaps when women have had a positive experience and they share that information with the women that live in their village or community, and then they find out it's not scary to go, and they may convince maybe just one woman that when they're pregnant to come and go and access care earlier. So I think it has to do a lot with education, and then what happens as that community spreads out with a message that, you know, you can really get a lot out of coming for prenatal care if you go. But there's always that thing of roping them in and getting them to come in the door the first time. And I think there's lots of barriers that are well beyond our control. In Malawi, we learned that there's all very ingrained spiritual beliefs about coming too early for care, that there's problems if you let people know that you're pregnant too early, and that can have adverse effects. And so there's a lot of spiritual beliefs that probably are going to take much longer than even just educating girls in school.
Just an anecdote. When I used to practice in South Africa, we had one consultant who was always more successful than others in getting accurate dating. And the reason was he always took time. And in South Africa in particular at the time in 1990s, women often went to informal care providers, pharmacies, or a GP there, or another doctor there, before coming to the hospital. And in the hospital, you were often overwhelmed. You know, it was always busy, and you ask, and she doesn't know. Okay, dates unknown. But he always used to take time and say, okay, when was the first time you saw any care provider, and this and that, and sometimes also check with the nurses about the language issues, because there are many local languages, and sometimes women are not comfortable in English. So I think if one spends time, because I don't believe that women just don't know anything about their dates and so on. But we often don't have patience and the sort of strategy to extract that information from people.
And then there was the question about sustainability.
So she said, what keeps me going? And I'll say that I have a vision. And so I practiced in the US for 17 years before moving back to Kenya 2 years ago. And I worked in the likes of the Johns Hopkins Hospital. I led directorship level positions in system hospitals for the University of Maryland and so on. So actually, this was my stomping ground. Mm-hmm. But I got to a place where I couldn't really see what I was doing. And so when you go into a low resource setting where I'm functioning right now, I'm seeing the lives that I'm touching. But not only are we touching lives, I'm seeing us raising the bar to clinical practice as well. And so for me, my vision in terms of, I lead a team of wonderful midwives, but I want to see them have a pathway to professional development in terms of expert clinicians, administrators, researchers, and so on. And so right now, actually, I was managing our first facility, have gone to our second facility. The person managing our first facility actually was a staff midwife. So once again, she has taken a step up in the role of management, an area where is very wishy-washy in sub-Saharan Africa. But she's taken, with my mentorship, she's taken on a role in leadership. And so when you have a vision and then you're seeing actualized, it makes a difference. Yeah.
I think I've always personally cared for the underserved in the communities in which I work. I work in Chicago, and we have no shortage of underserved communities there, as most urban settings in the U.S. But when you look at even our worst or most underserved communities here in the U.S., they pale in comparison to the suffering and ill health and that happens in the developing world. And so making even a small difference there, knowing what centering has done here for not only my own personal satisfaction, but for the women that I've cared for in groups over the last 15 or 20 years. I just know that it could make a difference because I think pregnancy is a universal experience, and as Sharon Rising, who developed centering, said, we are all meant to be in conversation, and I think that's what's missing, is no one's talking to each other, and that this is an opportunity for women's voices to be heard, and so I want to help make that happen.
Well, maybe I'll pose a hard question to you instead. When we talk about sustainability, there's the personal sustainability, but how can we provide antenatal care and make it sustainable in health systems with limited resources? Of course, that's to everybody, and that's a hard question, but I'll start with you.
I don't know. I think, antenatal care can be simplified or can be made complex, and the solutions need to be developed locally, I think. That's why we are struggling with this antenatal care guideline, why it's becoming so big and complex. What makes it sustainable is if something is developed and solutions are found locally, and I think that's what makes Jacaranda special, and you are making it local by going to Malawi and Tanzania. So it's something that one cannot be too prescriptive, I think, and at the same time, healthcare planners need help as well. So I think if the international community can help in that way, and that would be helpful. But the solutions, I think, need to be found locally.
I think you've brought this up many times, is that, in terms of the workforce, when you work in a setting, in a low resource setting, you do not have a lot of job satisfaction. And so the first opportunity that comes along that might get you out of that situation and into a different job where you may have a different potential for job satisfaction, you're probably going to take it. And there is a huge provider shortage in the places where I've been in Africa, and that and those are country issues. They have to build up the ability of their citizens to be able to get an education that allows them to then get an additional education at the secondary level, that allows them to go to university for training. And then looking at lower levels, so what are the abilities to create health service, community health workers or health service administrators that work in communities in conjunction with their trained providers. And so if we don't address those shortages, there aren't enough people to deliver the antenatal care. If there was, who knows how many, 500 more midwives in Malawi to deliver FANC, they wouldn't have to try to deliver FANC in 2 minutes. They'd have enough people to deliver FANC in the estimated time it takes, which is much longer than that. But because there's not enough people, and there's the people that are there aren't nurtured in their roles, and I can see from the point that you took that you have to bring people along and make them want to do their job and be involved in that and dedicated to that.
So cost effective. Something I learned here in the U.S. In my leadership roles was, we didn't want to keep clients in the hospital unnecessarily. It was draining our revenue and so on. Throughput, we wanted to get people in and out because we wanted volumes and so on. We didn't want to cause meaningless infections, hospital-acquired infections, because it kept people on and the payer won't pay you. Basic concept. We're running a business. And so one thing in terms of quality and system building is building efficient systems and measurement on an ongoing basis. One thing we have done is that we actually have a quality lead where we have value stream mapped most of our processes and redesign them to make them more efficient. Standardizing practice so that we have a better grasp on what the anticipated outcomes will be. It's a business, so we need to drive volume. So your marketing strategy, our community mobilize as our sales agents. They're going out into the community to get people in. Why? The more people I have, it has an impact on the bottom line. Recruitment and retention. So my workforce is my foundation. And so not only if I'm investing in them, I need to keep them because we'll put so much upfront cost in them. How do I retain them? They have to be happy. They have to be satisfied. They have to have the tools that they need to be able to provide good care. And then it translates to the patient satisfaction. If I have satisfied customers, they'll bring in more customers.
We have a question on the side here.
Hi, my name is Reem, and I work with Management Sciences for Health. Faith, I think you mentioned something about ensuring a seamless supply chain, and I wanted to know if you guys, any of you guys, could speak to issues related to the supply chain systems in ensuring that the right commodities are available, and how maybe you've been able to get around some of those challenges in your work.
Are there more questions on this side in particular? I have a bad habit of not seeing past the podium, so. No? Oh, there's one back there.
Just another brief question, Noah from from Friends of the Global Fight. I just wanted you guys to speak on two of the points that were made earlier. Carrie, you mentioned the importance of multi-sectoral health systems being able to address multiple issues in one location, but also Faith mentioned the importance of specializing and the importance of specializing in healthcare to be able to provide quality services. And I was wondering if that's a dichotomy or whether you can find a happy medium of those two.
Should we talk about supply chains first?
I think one of the key things that we have done in terms of supply chain is, number one, just knowing what is available. Number two, in terms of our system building, making sure that we have a good process in analyzing what we have in stock and so on. I think one of the big things, and this is in the area more so for family planning than ANC, is that, we rely sometimes on the government for certain commodities and their stockouts. And so building relationships, key relationships with organizations such as PSI and so on, guarantee us a seamless supply of some of these commodities, which we would rely on the government, but so frequently it's never there. Vaccines is an area we haven't cracked yet because, once again, that's a government commodity and we can't get them from everywhere because it's funneled in through the government system. So the vaccine area is sort of challenging, but in terms of other commodities, we've been able to, number one, build systems that are continuously monitoring what you have so that we're procuring on time, and number two, stakeholder relationships with key organizations so that we can obtain commodities from them.
In terms of drug supply chain, we are conducting a research project in Mozambique on improving antenatal care as an implementation research project. And the project started with the assumption that the main barrier to good antenatal care was knowledge gaps, and that education and training of providers would improve the quality of care. And we conducted a formative research, and we found that actually knowledge gaps were not the main issue, but the main issue was drug supply chain issues. So based on that formative assessment, now with the Ministry of Health in Mozambique, we've developed a system of kits. So all antenatal care related tests and supplements and everything are put in kits from a central location, and we are now starting the intervention phase to evaluate whether providing the commodities in kits is going to make a difference or not.
Carrie, unless someone else has another question, I heard you speak about how the model would be then scaled up in an urban population in Tanzania in terms of next steps. But I was wondering if you could speak a little bit more as to next steps, and then perhaps Faith, if you could add on to that. And then, we have Matt's in here, and we have an opportunity to think about policy implications. And he himself was talking about, needing to hear. So if we could, if either of you have anything to say, and then what you may have heard today from either the audience or the other panelists in terms of policy implications moving forward.
Well, in terms of scaling up, all of the places where we're going to be doing our work are a considerable scale up from anything we've done here in the U.S. So I think, at least in my mind, we're working on the theoretical knowledge that yes, it can work if we have A, B, C, and D, and we're going to hopefully find out what some of those barriers are when we do the randomized pilot trial. And I think that it requires the buy-in of the whole system, so it can't just be this little group in this little clinic. It has to be supported by the whole hospital-based system in a particular area, or it has to integrate with the hospital setting. In the urban area, the antenatal clinic is extremely separate from the place where they have their babies and where they're encouraging them to go for their babies. And so you can't empower a group of women to say, you want to make sure that this is what happens when you come to the hospital, and you make sure you have your birth kit, and then you go to the hospital and there's no room for you there, and you're sitting outside on the stoop, or a cleaning lady delivers the baby because there's not enough midwives there for you. So you have to integrate those systems so that what you help to talk to women about during their pregnancy is actually based in some reality of what's going to happen, because then if their expectations are not met, just like you said, they're going to come and say, well, it was great to get that care, but none of those things that you said would happened, and I didn't have a good experience. I should have just stayed home in my village. So we have to make sure we have to integrate those systems, and that, so you're not only changing the antenatal care system, you're changing what happens when women go to give birth, because that is a critical point. And if women felt respected when they got their antenatal care, yet they go to the hospital and they're not respected and they're not treated well, then they're just going to go back and say, well, it wasn't worth it. And so I think that that's one of the scale-up issues, is integrating those people to see that we're all part of the same process and everybody has to be on the same page.
I think as Jacaranda, we see ourselves as a laboratory for innovation. So we're testing out waters to see what works, what doesn't work. And with that, we want to share. So I think in terms of impact and scale, we want to have more facilities. But even if we have 5, 10 facilities, that doesn't make a dent on what we're trying to do in terms of reducing maternal mortality and so on. So what we feel we need to do sort of ties into our influence strategy. How do we build these public-private partnerships where we disseminate our knowledge, build collaboratives around it, and actually shift the way care delivery within the public system where people are going. So I really feel that's how we scale up what we're doing. So some of our interventions around quality and professional development for health providers, specialization. How do we take what we're learning and actually influence the larger industry in the country as a whole?
In terms of impacting on policy and scaling up, I think nothing beats a well-designed and well-executed randomized trial. This is an area where randomized trials have been done and can be done, and I'm very impressed that you are moving so early to this randomized trial.
We are always looking for funding, so if you could give me your card.
How much? No, because I think, through these randomized evaluations, we have, one, develop the focused antenatal care, and through more evaluations, we are identifying perhaps problems with it. And I think centering can be a winner if it's shown in randomized trials to have these initial fantastic effects. And I think it's a scalable approach. But I think we shouldn't shy away from rigorous evaluations if we want to have impact at the larger policy level.
Good point. Well, it looks like we have two questions in the middle of the aisle.
Good afternoon and thank you. My name is Sarah Timon and I'm from the American Society of Clinical Oncology, which actually a third of the members are from outside of America. So I have two questions separate, if I may. One, I was curious about I'm from the guidelines group, so I'm interested in what the inclusion criteria are for modeling studies. But if you don't know, if it's anywhere posted, I'd be interested in it. And I'm also curious about the relationship with OBs in Nairobi and with what you're doing. I believe I've heard about some intervention that has been tried in India. I think it was trying to get more women to have their babies delivered by OBs, and that there was mixed results with that. So I'm curious about that. Thank you.
Our relationship with OB. Oh, sorry.
Go ahead, I'll respond.
Go ahead, and then we'll grab the next question. You go ahead.
Our relationship with OB. So our first facility is midwife driven. Our second facility actually, I think, let me step back. Because we're dealing with lower resource settings, our goal is access to a skilled provider. That's the bottom line. And so raising awareness or educating the population about why it's necessary to access a skilled provider. My population will not necessarily have access to an OBGYN. They're typically private practice. Or in a higher level setting, it would be in the case of an emergency. But predominantly, we're midwife driven in the public and then lower resource private setting.
On the modeling, there has been one WHO guideline on cervical cancer that used modeling so far, and maybe you may know about it. But and I'm neither a statistician nor a modeler, so I don't know. But I think from what I understand, the techniques of modeling have advanced a lot, and this is an area where we can actually gather different types of data, both at the population level, ecologic level, and individual level. And I think that could allow us to play with model development and see. But I don't know if it will be useful in this case, but it's something definitely we want to look into.
So one of the neatest things I think about this program here at the Wilson Center is that we are able to archive all the webcasts from the different meetings that we have. And so last year we had a specific partnership with the Population Foundation of India, and there was a lot of discussions in the events where we featured either speakers from that organization or where we actually had a video conference come in from India to an audience here. There was a lot of discussion about the JSY scheme, which is the scheme that you were referring to in terms of institutionalized birth. So if you are interested, by all means, feel free to either search on our website or on our blog, and it will link you to the videos itself, and you can hear a little bit more about why it was or was not successful from the perspective of the folks based in India, and an audience actually based in India. I think there was another question in the middle, and then I see one in the back as well. I think the woman in the green.
Yeah, my question is for Faith. You had talked about the link between the private and the public side, which I think is extremely important because both have a lot to share and learn from each other. So what are the steps that you have taken? You obviously have done a fantastic job and with good quality of care. Some of the governments in the sub-Saharan countries are not always happy with the private side. They have their own challenges, and this is how to establish the link, especially when it comes to sharing of data and the quality of care. And they're also following what is sort of recorded in their local country HMI system, because sometimes even the causes of death, the way it gets recorded and reported is not always consistent. So what are the steps that you suggest and that you are taking to sort of improve the situation?
And then there's one in the back as well. I thought I saw one in the back, yeah.
You want the question now?
Yes, that'd be great.
Rhonda Brown, formerly with NAMRU 3, Naval Medical Research Unit, Cairo, Egypt. I just have a question for the woman on centering regarding what role OBGYNs can play in these centers where women are having their babies, where it's perceived necessary in order for sustainability and more of an integrative approach. How can OBs be helpful? Can they be helpful?
So a question around the links between public and private, and then OBs.
I think it's all about playing nice in the sandbox. And so what I did when I moved back to Kenya was strategically positioned myself. There are stakeholder forums that are open to the general public, and people don't know that. And so when the Ministry of Health has a reproductive health task force, everybody is invited. You don't see a lot of private payers, and if you see a lot of private players, it's UNFPA and so on and so forth. It's not these little hospitals that are coming up. So being strategic and sitting on those forums and being able to share what we do allows for the conversation to begin. I also sit on the National Nurses Association of Kenya, so professional boards, boards where there's opportunities for research and so on. And so we open up our facility to be that laboratory for research so that they can also see what we're doing, so insight. Devolution in our country, that's a word that has come up because our government system has now devolved into a county level system. So there used to be bureaucracy in terms of you have to go to the Ministry of Health to get anything done and so on. Now we're going to the county level. So you have direct access to governors and so on, who are now the change makers in different areas. Devolution brings competition. So now healthcare seems to be something that they're talking about now, because people now want to compete in what we're doing better in this county versus another. We're taking advantage of those opportunities and having conversations with county leads to say, how can we come into your county and help assist possibly managing some of your facilities, maybe assist in designing a professional pathway for your clinical teams. In terms of quality, how do we set a system? How can we assist you to set a system where you can measure indicators and so on and help that drive practice? So being strategic in where we sit, number one, but having conversations with key leaders now that they're accessible. 2 years ago, I couldn't say it was that easy, but it's actually easier to now have discussions at a leadership level, at a county level. And we feel that that's how we'll be able to sort of get our work disseminated in trying to push healthcare in the right direction.
In regards to obstetricians, in Malawi, in the rural areas where we worked, that was a non-issue. There weren't any. So there really wasn't any opportunities to engage them. My belief is that when we're in a more urban area, and certainly in the capital in Malawi as well, and in Tanzania, where there will be a more diverse provider population, obstetricians can lead prenatal groups too. We have seen that happen all throughout the U.S., and it's less about what credentials are after their name than their ability to be able to engage with women and want to give care in a different way. I would think that the best, in resource-poor countries, the best use of that very scarce resource is to have them caring for women with high-risk pregnancies. Because in the countries in sub-Saharan Africa, midwifery is the model of care for the majority of women, and it's really women with risk factors that could benefit from having care that may be jointly led between a midwife and an obstetrician, or solely in a setting where there's obstetricians.
I see one on the side here, the side I tend to neglect.
Hi, my name is Francesco, and I'm with the Institute of Medicine. My question's for Carrie. When in our current health system, we have a huge disconnect between research and practice, and it can take many, many years for research to translate into effective practice. So as you're conducting this research in the coming year, how do you bridge the gap and translate this research into effective evidence-based clinical practice?
I saw a hand come up over. You have a minute or two to think. I saw a hand come over here. A process.
Faith, my question is around in part the earlier discussion around integration of services, and the TB question was one example where, it would be great to see integrated disease screening. But I understand in your operation, you stated you're not covering potentially comprehensive disease screening, certainly not treatment. So could you speak to the referral system that you have, and if that works effectively, and what makes it work effectively, perhaps?
We only have a few more minutes left, so if there was anybody else who was thinking about a question, I think now is the time to raise your hand, and we have one over here.
Hi, my name's Katie Millar, and I'm with the Maternal Health Task Force. And since the theme of integration has come up, one of my questions for all of you is how we're limited to integrate by funding mechanisms. That often funding is siloed. You have funding for a family planning program, for an antenatal care program, for an HIV program. So how much of it is the ability of the system to integrate versus the ability of funding to collaborate to create integrated care if and when necessary?
So we have funding questions, integration questions. Does anybody want to get us started?
Well, I'll try to tackle your question. I think it would be awesome if we find that in Africa we can finally answer that question, because we certainly haven't done a good job of answering that question here of how we efficiently and in a timely manner translate evidence into practice. I think it's, the last statistic I heard, it's about 17 years. Well, we need to step that up because lots of people are having really poor outcomes because we're taking so long here in our own country as well as in Africa. So I wish I knew the answer to how we translate evidence into practice. Maybe there are different kinds of barriers there that may allow that to happen faster. I hope so, but I don't know that for a fact. I think there are different barriers there. Some of them are funding barriers because it's a low resource setting. But I don't know that because we don't necessarily have the entrenched other entities such as third-party payers and big institutions that have a lot of maybe skin in the game to keep things the way they are, that maybe in Africa where they are seemingly wanting to change and want to improve health, that maybe that will make it easier. You'll have to check back with me next year and I'll let you know how that's going.
Integration of services. So
We do screening, malaria, STIs, syphilis, and so on. We do cervical cancer screening and so on. So we do engage in basic screening. In terms of our referral system, we have good relationships with the public and private players. We did a lot of vetting about what their what their capabilities are, and so on, and then have put systems in place, documentation and so on, that sort of speak to where we refer our clients and so on. So does that answer the question?
Can we just grab you a mic so that the folks tuning in could hear you?
Yeah, just a quick. I was wondering, do you follow up on those referrals? Is it 360 degrees where you're?
So we follow up with the clients. We don't follow up with the facilities. We don't have the ability to follow up with the public sector referral. They don't take your phone calls, So we actually do a 360 in terms of following up with the client.
Yeah. On the issue of integration, I think we are kind of talking about integration always in a positive sense. And that may or may not be the case, depending on what kind of integration we are looking at. And it's true that in some cases, donor funding into vertical programs may not have helped. But I think integration also, we need the evidence base to be able to comfortably say that in certain ways integration is better than non-integrated ways, forms of care. And this has certainly been one issue when people try to integrate family planning and STI services together, for example. That led to some people falling off the services altogether. So I think, obviously the ultimate integration is when you have one person running a primary care center, then that person has to do everything. But what I'm trying to say is I think the healthcare planners need to consider these things in a sort of logical and preferably in an evidence-based manner. There have been systematic reviews of different integration models, and some have been more successful than others. So I think that requires evidence like anything else. And just on that, I think going from research to practice, it's a similar issue. I think when you are just letting passive diffusion, we know that it doesn't really have an impact, at least not in a short period of time. But there have been a number of different strategies evaluated, like multifaceted strategies, use of opinion leaders, educational outreach, that have been shown to have modest but consistent effects.
I wanted to make a comment about your integration issue, and I think that, women's health has existed in boxes. So we have, women's health during her pregnancy, and then we found out, well, if we don't have a healthy woman when pregnancy starts, then the pregnancy won't be healthy. So then we started on preconception care, but then we found out, well, if it has to start before that, because they have to be born healthy and they have to get the right kind of nutrition and they have to go to school, and so it's this sort of box mentality that health is a continuum, and if we don't address the health at every sort of level, then by the time we get to pregnancy, it really is probably too late. And so that funders, I would hope, would wake up to the idea that, yes, HIV is important, but if we only think about HIV in this one little box of a woman's life, then we're missing a lot of opportunities and perhaps not being able to provide her with the interventions that will make her healthy as well as her future children. And so I think funders have to start thinking outside of the boxes that we've been working in for, I think, way too long.
So, on that note, I do want to thank you all for making this such an interesting discussion and ask you to join me in thanking our speakers as well. And I did mention our website and our blog, but we are also on Facebook, and we mentioned Twitter earlier too. So definitely continue to keep these conversations going. The funder question in particular.
Thank you.
Thank you.
Thank you. Back that glass of water.